So why do we use neoadjuvant therapy? So this is an age-old question. So firstly, for breast cancer patients who definitely cannot be operated, that is the inflammatory and other inoperable case scenarios, and also to make BCS more feasible and reduce the complications of surgery, and also reduce the need for revision for residual tumor. Now, when HER2 positive breast cancer patients, after the Catherine data, we have response adjusted therapy or response adapted therapy, where people who do not achieve a PCR and with a significant residual cancer burden, especially graded by the RCB grading, will definitely benefit from adding TDM1 in the adjuvant setting. And it has clearly showed by reducing the invasive breast cancer disease-free survival by around 50%. Also, we have proved beyond doubt with multiple meta-analysis, especially the one published in JAMA in 2016, where more than 5,000 patients across multiple studies were evaluated, which shows that PCR can be taken for long-term clinical benefit, especially in HER2 positive and hormone negative setting, where there's a 50% reduction in the risk of disease recurrence. And in the hormone setting, it's around 30 to 40%. Yeah, so I was just talking about the CT-NEO-BC is another meta-analysis when an international working group known as the Collaborative Trials in Neoadjuvant Breast Cancer was commissioned by the FDA to investigate PCR as a surrogate endpoint for long-term outcomes. And the CT-NEO-BC also included triple negative breast cancers, but there was another analysis published in JAMA, which mainly concentrated on HER2 positive. And so this proves that PCR, which is commonly used in most of the neoadjuvant trials as an endpoint, could be actually true and to predict long-term clinical benefit. So now I'm going to talk about two trials which have used dual HER2 blockers in the neoadjuvant setting. Both are phase 2 trials. One is the NEOSPHERE and the other is the TRIFINA study. And the primary endpoint of both the trials are different. So while PCR was the primary endpoint of NEOSPHERE, TRIFINA actually studied the tolerability and safety of using dual HER2 blockade with chemotherapy. And jumping on to NEOSPHERE trial, it was a phase 2 trial where 417 patients were randomized to 4 arms, the first arm being Herceptin plus docetaxel, the second arm being Perjeta, Herceptin plus docetaxel, third arm being pertuzumab plus Herceptin without any chemotherapy, plus docetaxel without the pertuzumab. And after this, patients underwent surgery and all of them received adjuvant anthracyclines along with trastuzumab. So the key eligibility criteria that was used was operable, locally advanced or inflammatory breast cancer, which were HER2 positive by the CAP criteria, no metastatic disease or bilateral breast cancer or any other malignancy other than cancer in situ of the cervix or basal cell cancer, no previous anti-cancer therapy or radiotherapy for any malignancies. And the primary tumors had to be more than T1, more than 2 centimeters, and no cardiac dysfunction or even insulin-dependent diabetes. So what they definitely found was dual HER2 blockade was associated with higher PCR rates. It was 45.8% where pertuzumab, trastuzumab, and in the docetaxel arm. And the 5-year DFS data also showed that with usage of dual HER2 blockade, the 5-year PFS was much better. So was the DFS. And coming to the most important thing, we are using 2 HER2 blockers. What about the safety? What they found was the safety across all the groups were comparable. In fact, the trastuzumab and docetaxel arm had more neutropenia compared to the dual HER2 blockade. And even in the adjuvant setting, when trastuzumab was used along with FEC, also the adverse effects were quite comparable. So this did not show up any new red flags. So they summarized that a PCR rate of 45.8% versus 29% with dual HER2 blockade versus using only trastuzumab respectively. Substantial anti-tumor activity and a favorable therapeutic ratio for trastuzumab and pertuzumab doublet without chemotherapy, but patients here received the taxane and anthracyclines in the adjuvant setting in this arm. But we all know HER2 positive breast cancer is biologically more aggressive. So initially, historically, we know that chemotherapy definitely does well when used in HER2 positive. So the whole concept of avoiding chemotherapy, unless in a case-to-case basis where patient is definitely medically unwilling or medically not fit for giving chemotherapy, we usually don't avoid chemotherapy. Pertuzumab and trastuzumab without chemotherapy also eradicated tumors, but that is not followed routinely. No meaningful increase in cardiac risk with pertuzumab over a short course of 4 cycles of neoadjuvant therapy was seen. So this was a phase 2 trial. Coming to the other trial, which is a TRIFINA trial, where again, the primary endpoint here was the safety and tolerability of neoadjuvant treatment, especially the cardiac safety. The secondary endpoints being PCR, DFS, OS, and other biomarker evaluation. One thing which is important with this study is this evaluated a anthracycline-free regimen in terms of pertuzumab plus trastuzumab plus docetaxel and carboplatin given for 1 to 6 cycles. The other two arms were pertuzumab, trastuzumab plus FEC followed by docetaxel plus the dual HER2 blockers. And the other arm being only anthracyclines followed by dual HER2 blockade plus docetaxel. So this was mainly done to evaluate the cardiac safety as the primary endpoint. And patients after surgery were allowed to complete Herceptin up to a total duration of 1 year. So what did they see? The eligibility criteria was the baseline characteristics were generally balanced between all the treatment arms. And one thing to note here was there were slightly less patients with ER positive and or PR positive tumors in arm B, and there were slightly more patients with HER2 positive IHC 2+ tumors in arm A. The third point is what is important. The proportion of patients with operable breast cancer was lower in arm C, that is the anthracycline-free arm. Correspondingly, more patients in this arm presented with locally advanced disease. So we are treating a locally advanced breast cancer with an anthracycline-free regimen. And what they found was the side effects, which was the primary endpoint, was actually not very different in the neoadjuvant setting. But what I would like to point out here is in the adjuvant period where the patient is receiving only Herceptin or trastuzumab, they found the LV decline of more than 10% from baseline to less than 50% was almost double in the arm B, where they used FEC3 followed by dual HER2 blockade, and compared to the other two arms, which is quite surprising, where though the dual HER2 blockade was used with anthracyclines in arm A, the difference was seen more in the arm where anthracyclines was not compared. So with this, we could say, though we don't routinely use it in a setting where we have to, we can actually combine it with anthracyclines. So the PCR rates were higher in arm A and arm C, where pertuzumab and trastuzumab were given for 6 cycles before surgery. So that could be the reason why the PCR rates are higher in arm A and arm C. And the DFS were nothing much to choose here. So all the 3 arms had actually showed a median DFS of 87, 88, and 90% at the end of 3 years. But that wasn't the primary endpoint here. And OS also is almost similar across all the 3 arms. So they summarize that a low incidence of symptomatic neoadjuvant and adjuvant periods. So concurrent administration of pertuzumab plus trastuzumab with epirubicin resulted in similar cardiac tolerability compared with sequential administration or the anthracycline-free regimen. Neutropenia, febrile neutropenia, and leukopenia and diarrhea were most frequently reported adverse effects across all arms. So regardless of the chemotherapy chosen, the combination of pertuzumab with trastuzumab in the neoadjuvant setting, especially if given for more than 4 to 6, up to 4 to 6 cycles, definitely increase the PCR with just trastuzumab alone. So we know with chemotherapy, we hit almost around 25 to 30%. With trastuzumab, it goes up to 45. And with dual HER2 blockade, we can achieve a PCR of up to 60%. And taking that PCR and translating it into a meaningful clinical benefit to our patients has already been established. So in especially patients with more than 2 centimeters or lymph node positive breast cancers, we have to, I think, with this data, offer dual HER2 blockade to patients who can actually take it. And that's what the NCCN also says. So though it also recommends only trastuzumab with carboplatin and docetaxel, dual HER2 blockade and the taxanes and carboplatin is also an acceptable regimen. Thank you.